Hi there. Welcome to this exciting segment of HRS TV on personalized therapy guidance, the next frontier in improving persistent AF outcomes. I'm Mina Chung from the Cleveland Clinic, and I'm joined here by Dr. DJ Lakkireddy, who's the Executive Medical Director of the Kansas City Heart Rhythm Institute, and Dr. Doug Gibson, who's Director of Cardiac EP at the Scripps Clinic in San Diego, California. Today, we're going to be talking about the importance of a personalized ablation strategy in improving outcomes and minimizing ablation of healthy tissue for patients with persistent AFib. We're going to be discussing some of the challenges in mapping and ablating non-pulmonary vein triggers and some potentially novel approaches to help doctors identify patient-specific substrate and triggers outside of the pulmonary veins to optimize treatment plans, which also leads up to a late-breaking clinical trial that will be presented at Heart Rhythm Society HRS 2023. So to start us off, I want to kind of talk a little bit about the data that may inform us a little bit about ideal treatment strategies for persistent AF, because this has been a very controversial area. Because recent PVI plus studies haven't really shown a benefit over a PVI alone strategy. So one of the key questions is, how can we do better? And are there so-called personalized approaches to ablating persistent AF? So I'm going to turn to Dr. Gibson and Doug. Are there any positive studies out there that suggest that there are better approaches to target the substrate for patients with persistent AF?
Thank you, Mina. I happen to be in San Diego, and Acutus started up in San Diego, so I kind of got word early that this system was being developed. And they have a couple interesting data sets. The first one that they brought forward was Uncover AF. So this is a non-randomized but prospective study. They're in persistent AFib, single procedure success rates, 1-year success rates, 73% for AFib only and 69% for all arrhythmias. Those are respectable numbers. So it kind of drew some attention from me. So Uncover AF was interesting. And then they also more recently, in 2021 in HRS, Dr. Shi published a study looking at what they're calling core to boundary. So this was a smaller study, 40 patients, but they were propensity mapped to another group of patients. So let me just clarify that. So one group had PVI with core to boundary. A propensity match group was looked at, including PVI and posterior wall. And so what they saw there is freedom from all arrhythmias in the core to boundary group at 68%, and in the PVI plus posterior wall group, freedom from all arrhythmias at 46%. So again, propensity match, but good numbers, supportive evidence that, hey, we may be doing something meaningful here. Obviously, we're trying to settle in on a core to boundary strategy or a substrate mapping strategy that then we'll move forward with and do a randomized prospective trial. So that's, I think, what I'm most looking forward to.
All right. And then what about redos, like repeat?
Yeah. So this was another more recent interesting study, and this is called the Recover AF study. And they looked at patients that had a previous ablation. Now, you could have had PVI or PVI plus in the previously ablated group. You may have had cases where PVI alone was done, or PVI plus linear ablation, or PVI plus something else, right? And so what they did is they grabbed these failed first-time ablation patients and they brought them back and mapped them with the Acutus system. And but in all patients where you retreated them, and this is allowing for multiple retreatments with the AccuMap system, in all patients in this group, they got an overall 76% success rate. So not bad for a redo patient population. One of the more interesting aspects of that study was if the baseline procedure was PVI only, and then they had a failed PVI only procedure, you went back in with the AccuMap system and you re-isolated the veins, but then did core to boundary approach. In that group, again, the key point here is they only had PVI as their base procedure. You got 91% success out of that patient population. On the flip side of that, if you had PVI plus as your baseline procedure that failed, and then you went back and remapped with the AccuMap system, you only got 63% freedom from all arrhythmias in that group. So PVI plus seemed to decrease the success rate when you went back and remapped and targeted these patients with core to boundary. Again, PVI alone, with remapping and retreatment with the Acutus system, you got 91% success rate. So again, very good supportive evidence that these cores matter, and by targeting them, you may be able to get increased success out of redo patients.
So does this imply that are you saying we should just do PVI alone? Because
maybe it implies that. I wouldn't put
Yeah, one of the interesting things too that you're saying is that, now, are you ablating less area than you would in, other substrate?
Yes, yes. I think there's the potential for that, the significant potential for that. And that's mainly what I'm most hopeful for with this system. Again, we need randomized prospective data, but it appears to me there's a little more work to be done on the exact substrate and how we should target it. Should we map it in sinus rhythm looking for slow conduction, or should we be trying to identify cores in AFib? So there's different ways to do this, but at some point, maybe after another couple setup studies, we'll settle in on an approach and do a randomized prospective trial. And yes, that'll answer the question, can we get away with good cure rates by ablating less?
Okay, thank you. Well, let's turn to triggers. Sometimes it's really hard to figure out what those non-pulmonary vein triggers are. DJ, thoughts about personalizing ablation with trigger mapping?
Mina, thank you. Fascinating area for exploration and all, right? So I think it's quite clear that pulmonary vein isolation forms the foundation for the core of what needs to be done. But again, we have this entire evolution of the atrial substrate and the role of the non-pulmonary vein triggers and the substrate itself, which we really don't know much about, right? But so the ground reality of it is, despite all the developments that we had, we did not reach so far to be able to really quickly identify these focal triggers that oftentimes are very infrequent. And it's impossible to really map them with the existing multipolar electrode mapping systems that are popularly available at our disposal at this point in time, right? So if there is a way for us to really do a single beat mapping very accurately, giving us an absolutely perfect geolocalization of these focal triggers in a three-dimensional space that can be accurately be pinned to a certain region of the atrium, and by targeting those areas, can you make a difference, right? I think that's kind of what I was really fascinated by the AccuMap system. Number one, it gives you a perfect structural anatomy, sort of the wall chamber limit, that is very reproducible. It is as good as your CT scan. And then you can overlay sinus activation on it. You can overlay a focal trigger activation on it, and then precisely tell where exactly a recurrent, repeated focus that fires and introduces atrial fibrillation. I think that is the best value that I see in this. So now I've switched my practice to a point where whenever I have a redo ablation, when I suspect that the pulmonary veins are probably isolated because the current technologies are so good that durable pulmonary vein isolation is a reality. And now you bring in these patients, I float the AccuMap up, and then I challenge them with isoprel and if necessary, sometimes calcium, sometimes phenylephrine. And we look for focal triggers, repetitive firing happening at a frequency of at least 4 to 5 beats every minute will give us some sort of frequency repetitiveness of that. We target those, and then we ablate those areas. What we did with our trigger mapping study that you alluded to earlier, that will be presenting as a late breaker science in HRS. So what we were able to see is some fascinating correlations between localized conduction velocity and sort of, are these localized conduction velocity abnormal conduction velocity areas, do they really correlate with focal triggered activity? And what does it really mean in terms of overall substrate? And if we really take this forward, right, if there is a way for us to be able to assess the presence or absence of scar based on voltage mapping, and then correlate it to the conduction velocities, and then pin the focal triggers on top of it, I think we might have really, uncovered something here. Something really significant that the field really needed in changing the paradigm for the non-paroxysmal atrial fibrillation ablation. So I think the future looks very bright. And by being able to use good ablation tools, and by being able to use some innovative mapping technologies that would enable us to simultaneously give a better understanding of the substrate as well as the focal triggers, we can perhaps stop demolishing the atrial tissue. To Doug's point, I agree with him. I'm one of those guys who ablate a lot, right? I'm taking out the posterior wall, I'm taking out the lateral wall, I isolate the appendage or ligate the appendage, and I'm ablating the floor. I isolate the SVC, IVC, CS. In the end, yes, it works, but at what cost? And can we come up with a better, elegant solution where we don't have to kill the entire atrium? I think would be a welcome change to our practice.
Yeah, I agree. That's the holy grail. I think they would desperately need it in the field.
So I think this is a very fascinating area. All these years, for lack of tools that would enable us with rapid mapping capability of this very short-lived and unpredictably reproducible arrhythmias, we were hamstrung by the limitation of technology and not having enough tools in our hand, right? I think this tool really changes, in my opinion, a lot of these shortcomings. And I'm sure there are many others thinking on the same lines to really solve this particular problem.
I just want to ask your ideal mapping system paired with PFA, or what does it look like? What does that look like?
I think the fundamental problem, in my opinion, is lack of proper understanding of the substrate and the targets of what to ablate, right? Yeah. So with PFA really giving us the ability to do quicker, faster, safer lesion, if that can be combined with a superior mapping tool, maybe would have answered or solved the puzzle for the non-proximal effect. So I think I like the way or the direction which our field is going, the simultaneous enhancements in the understanding of the substrate triggers mapping capabilities, and also introducing the PFA on the other side of the equation.
Yeah, I think the key is the global activation, right? That, we have good mapping systems out there now. We do not, aside from Acutus, we do not have one that gives us good global activation. We like to see the triggers reliably and quickly, right? And that's the problem with contact mapping. You got to move your catheters around the inside of the heart and, get lucky. Your PACs have to show up when you have your mapping catheters in certain locations. So global activation, I think, is key for triggers, obviously, but also for substrate too. We have, again, good contact mapping systems for voltage and small fragmented electrograms, but to see the function of those regions in the midst of AFib, or to see the function, the slow conduction velocity associated with those regions in sinus rhythm, I think is key. So I like the global activation. I do think, AFib is not one size fits all, as DJ mentioned. There's whatever mapping system allows me to get good success rates by ablating less. That's my ideal mapping system. And, there's some potential here.
Okay. Well, thanks. Let me try to sum up, and thanks very much, both of you, DJ and Doug. It sounds like our current generation mapping and ablation systems have been limited in our ability to identify non-pulmonary vein triggers and substrate, but there's a lot of hope out there now. We have maybe some global non-contact mapping systems that may allow us to better identify and understand triggers, slow conducting zones and cores, and other relevant substrates that might improve and personalize our ablation strategies for persistent AF. But we really do need a lot more research and randomized trials to test these approaches. And it'll be really important to show their effectiveness and the safety of ablating persistent AF beyond pulmonary vein isolation. So thanks very much. Thanks for your attention to our audience watching.